a brief literature review because there's actually not a whole lot out there about this as far as just the number of patients that have had this problem. We're going to talk about the surgical approaches to this type of a situation, and finally a brief discussion for our conclusion. So our story starts with a 52-year-old female who initially presented to the outside ED. She had some lower abdominal pain and some bladder pressure that had been kind of building over the past several weeks. Her initial review of systems was just showing urinary urgency. She had some mild diffuse abdominal pain. She said she had no change in her bowel habits, and otherwise she was relatively normal. She got a CT at the outside hospital, which we'll review here in just a second. It showed a large pelvic mass that was presumed to be some type of a lipoma, although exact type not known. Overall, her physical exam was unremarkable. She did show some mild diffuse abdominal pain, but no type of focal abnormalities. Secondary to her history of vulvar intraepithelial neoplasm, she was initially let go home, but was sent to her follow-up with her GYN oncologist. At that time, she had a pelvic exam, which was also unremarkable. And because she did complain of some back pain, she also had an MRI spine, which we won't review because it was grossly normal and didn't really go down low enough into the pelvis to get a great view of our mass. She was subsequently sent to Dr. Jean for continued evaluation of this pelvic mass. So here are her outside images. We'll start at the beginning of the pelvis here. What you'll see here in just a second is a mass that's the density of fat protruding from the right pelvic sidewall. This is a pretty slow thing, but there you go. Now you can see it right here as it kind of begins to, I can't see that, as it begins to kind of press on the bladder right there. It goes down further, and then you can see the mass as it protrudes into the anterior aspect of the right thigh as well. So we'll take a look at it from a couple different images here. And this actually gives a great view of how the mass starts in the anterior thigh. You can see as it now protrudes, what you can tell is through the obturator canal right here, and actually into the pelvis again, compressing the bladder and the rectum. One last image here, just another good view of how the mass actually is one continuous mass that goes from the pelvis into the rectum, or from the pelvis into the leg, or vice versa, I guess, depending on where exactly it started. So I'm going to talk a little bit about the anatomy of the pelvis. We as surgeons spend a good amount of time here, but not as much as we do in the abdomen. So I thought a little bit of an anatomy lesson would be helpful. The bony pelvis is a basin that's shaped out of 4 bones. There are 2 hip bones, which consist of the ilium, the ischium, and the pubis, and there as well as the sacrum and the coccyx. The bony pelvic inlet is bound posteriorly by the sacral promontory, laterally by the iliopectineal line, anteriorly by the superior aspect of the pubic symphysis. And the bony pelvic outlet is bound posteriorly by the caudal sacrum, the coccyx, laterally by the ischial tuberoses and the sacrotuberous ligaments, anteriorly by the inferior aspect of the pubic symphysis, and finally the ischiopubic rami. Here you have the obturator canal, which I was talking about of our CT scan. It's made up of the ischium and the pubic bones with a membrane traversing between the 2 structures. The blood supply consists of the internal iliac artery, which divides into anterior and posterior divisions. The posterior division is actually pretty rarely seen. It dives back posteriorly and supplies the gluteus region with the superior gluteal, iliolumbar, and the lateral sacral arteries. The anterior division has several branches, but I'll only point out the ones that can be seen usually during a retroperitoneal surgery. And this consists of the superior vesical artery, the uterine artery, and occasionally, from what we saw, the obturator artery. And finally, the pelvic diaphragm is the central component of pelvic support. It lies retroperitoneal and is formed by the levator ani muscle group and the coccygeus muscle group with fascial coverings. The levator ani is composed of three muscles: the puborectalis, pubococcygeus, and iliococcygeus. The superior fascial layer of the levator ani muscle group projects cranially. It envelops and supports the bladder, superior vagina, uterus, and rectum, and the inferior aspect of the fascial covering extends caudally onto the urethra, distal vagina, anus, and it fuses with the urogenital diaphragm. The point of all this is that the pelvic diaphragm must maintain a constant state of tone to provide support to the pelvic structures. So our patient had and was presumed to have some type of lipomatous structure. These can be generally divided into four categories total. The first would be an infiltrating or diffuse neoplastic or non-neoplastic proliferations of mature fat cells. This is like a lipomatosis. These can cause compression on multiple vital structures, can become quite large. You can also have things like variants of lipomas. These are less common and they differ in both microscopic and clinical picture from just a normal lipoma. These can include things like angiolipomas and myolipomas. And finally, there are two types of solitary lipomas, and they can be easily distinguished. There are subcutaneous lipomas. This is the ones that we see most commonly. They're just composed of mature fat cells, and they arise in superficial tissues. They're by far the most common mesenchymal neoplasm. As we know, we all usually see them on the upper back, neck, shoulder, and abdomen. And finally, you can have some deep lipomas, which, oh, sorry about that. And finally, you can have some deep lipomas, which are more rare, and they arise and are intimately associated with deep tissues. They have subdivisions such as angiolipoma, intramuscular and intermuscular lipomas, lipomas of tendon sheaths. There are neurofibromatomas and lumbosacral lipomas. These are often detected at a relatively late age, and thus they can tend to be very large, such as one in our patient. Because of this, they can lead to things like nerve compression, erosion of bone, and focal cortical hyperosteosis. These deep lipomas tend to be less well circumscribed. The contours are often determined by the space in which they occupy, such as the one you see here, which is actually an intrathoracic lipoma. These things right here can extend from the upper mediastinum into the neck, the subpleural region, the subcutis of the chest wall. Sometimes they assume an hourglass configuration, kind of like you see here. And as we know, as surgeons, there are also kind of deeper lipomas, such as the fatty proliferations around the umbilicus, or those in the inguinal ring, which can be associated with indirect hernias or merely just kind of simulate a hernia on exam. So this type of a deep pelvic large lipoma has been described previously in the literature. This was published by the Mayo Clinic. They described a 51-year-old female that presented with chronic pain in the left groin. She actually underwent a vaginal hysterectomy for this, where they removed fibroids. However, she had no relief of her pain. She underwent a colonoscopy, CT, and MRI that eventually revealed a 10 by 8 centimeter dumbbell-shaped mass that was in her pelvis, protruded through the obturator canal, and extended into the adductor region of the proximal thigh. Like our patient, she received no preoperative biopsy. Mayo's surgical approach was this, as they typically do. They got a very fancy multidisciplinary team together, consisting of a colorectal surgeon and orthopedic surgical oncologist. They started with a low midline incision. They exposed the mass by entering the avascular presacral plane, immobilized the rectum anteriorly and laterally. And the pelvic portion of the mass was exposed by splitting the pelvic floor muscles. They were unable to completely get the mass out of the compartment of the leg and into the pelvis, and so the orthopedic surgeon actually made a counter incision, which was medial in the thigh, and then detached the adductor tendons anterior medially, exposing the obturator canal. They then pushed the intrapelvic portion of their mass through the foramen into the anterior compartment of the thigh. They were able to completely excise the mass but then the adductor muscles had to be reattached at that time. The histopathologic analysis that they had on their structure was a benign pelvic lipoma as well. Other types of large pelvic lipomas have been described in the literature, although they are rare. This is a giant retroperitoneal pelvic lipoma that presented like a dumbbell type lesion. It occupied the entire lesser pelvis, as you can see here, and it actually protruded through the sciatic foramen into the gluteal region of the patient, also requiring an abdominal incision as well as a counter incision on the patient's gluteus. So for our surgical approach to this patient, we first placed our Foley catheter. The abdomen and right groin were both prepped and draped in sterile fashion. We made our lower midline incision, and we conducted a lysis of adhesions within the pelvis. We were then palpate within the pelvis, lateral to the bladder, and inferior medial to the iliac vessels. We were able to encounter a large pelvic mass kind of in the preperitoneal space. We incised the peritoneum. We were taking care at this time to preserve the vessels and the bladder. We used a combination of electrocautery and blunt dissection. We dissected down to the pubic rami, and then we're able to work our way over to the obturator canal. At that time, it was clear that the mass was, number one, extending through the obturator canal, but also densely adhered to the obturator membrane as well. And here you can see us, and it's not a great picture inside the abdomen there, but you can see our picture into the pelvis, and we have reached the mass at that time. Like our colleagues at Mayo, we were unable to deliver the mass into the pelvis, and thus we moved on to our counter incision as well. We did this on the medial thigh, medial to the vessels, and just lateral to the pubic tubercle. Our incision was carried down to the anterior fascia of the leg, which was incised. We retracted the gracilis muscle medially, and then we actually just kind of spread the fibers of the adductor longus longitudinally, which we were able to reveal our mass by just spreading the fibers. We then conducted a blunt dissection up to and within the obturator canal from both above and below, and I'll show you a picture of that here in just a second. Being careful to avoid the structures I talked about earlier, like the obturator nerve, artery, and vein. After a long process, a difficult blunt dissection, you can see Dr. Jean here dissecting out bluntly from superiorly and inferiorly, both within the pelvis and the leg. We were able to get the mass through our portion of the pelvis and into the leg, and so we retrieved it from the leg incision. We then were introduced with the problem of the defect within the obturator canal and the obturator membrane. We felt that given enough time, this also could present as a problem for the patient. So we chose a piece of pro-grip mesh, which we just laid over the obturator canal in the preperitoneal space. And then we used a running 3/0 vicryl to close the peritoneum, thus a pretty easy fix for the obturator hernia at that point in time. And finally, we closed both the leg incision as well as the abdominal incision in standard fashion. This was the pathologic specimen that we came up with. It ended up being a 3.5 by 8 by 1.8 centimeter benign lipoma. During the postoperative period, our patient did relatively well. On her initial post-op check, she was able to urinate, she had minimal distension, and she was what we would call appropriately tender to palpation. On post-op day 1, she did complain of some mild leg pain. She had no neuromuscular deficits though, and she was given a regular diet. And on post-op day 2, she was having normal bowel function, urinating without difficulty, ambulating. Although she did have a significant 40-pack year smoking history, she did develop some respiratory insufficiency, and thus her discharge was delayed until post-op day 7. So what did we learn from this patient? Lipomas are benign encapsulated tumors that can acquire any shape and grow in tissue planes of the path, usually the path of least resistance. Like in real estate, benign tumors, location is everything. For pelvic lipomas, they can become considerable size. They cause local problems such as pelvic pain, bladder outlet obstruction, constipation, venous obstruction, lymphedema, and even sciatica. In the literature review that I did, I found only 3 previous descriptions. We talked about one of them. Another one was a recurrent thigh lipoma, which actually went up into the pelvis, and the other was a primary pelvic lipoma, as far as tumors that are going through the obturator canal. And as I showed, there are other pelvic tumors, although rare, that go through things like the sciatic frame as well. Differential diagnosis for soft tissue masses in the pelvis is usually comprised of things like lipoma, pelvic lipomatosis, some of the atypical lipomas that I spoke of, or one of the lipoma variants, or even a well-differentiated liposarcoma. The diagnosis for these should be something like a CT or an MRI. In the literature that I looked at, there are less useful techniques such as PET-CT and endorectal ultrasound, but I didn't find anything that really showed that those are very useful. Things like transrectal biopsy were also described, but really the biopsy of these should just pretty much be a CT-guided biopsy. You can get your cytologic and usually histologic analysis most usefully that way. On MRI, simple lipomas have iso-intent signal with fat. They may have some small linear internal septations. However, if these septations get more thickened or nodular, you need to start thinking about other things than just a simple lipoma like ours was. There can be a higher likelihood of atypical lipoma, lipoma variants such as the angiolipomas, or even the well-differentiated liposarcoma. And finally, the combined abdominal ischiopubic approaches clearly has been described in the literature, and it provides good exposure of the tumor. It allows you to access 2 different compartments within the patient simultaneously, and it is a good approach for tumors that are in both compartments at the same time. And finally, in our case, 2 well-trained general surgeons, Dr. Hunt and Dr. Jean, I believe are probably just as good as the colorectal surgeon and the surgical oncologist at Mayo. And that does it. Questions?
Speak a little bit. You did touch on biopsy. I think for the benefit of everybody here, especially residents, and we talk a lot here in this conference about oral board exam. Talk a little bit about the pros and cons of pre-op biopsy in this a little bit more now. I mean, how are you going to answer that question? Somebody throws you up that CT scan. Is there a right or wrong answer to that? I guess.
I guess that my first answer to that would be I don't think there's a perfect answer to that question. I think if it has worrisome characteristics, you're going to take it out either way. And if it's symptomatic, like in our patient, even though she only had kind of small septations, you're going to take it out either way. I think that if you are anticipating my understanding of what where I read in the literature, if you're anticipating a difficult operation and you are weighing out the pros and cons of doing an operation, period, I do think that a biopsy is a good technique to give you the ability to discuss in a more intelligent manner all the options with your patient. However, if you think it's the possibility of a liposarcoma or something along those lines, I think you're going to end up doing a resection and send to frozen no matter what. And if you're really concerned of like an angiolipoma, I think the concern with things like bleeding and things like that would prevent me from biopsying as well. I think for the most part with my patients, I would go straight to resection if it was symptomatic or worrisome.
So back to your issue of imaging, helping distinguish. I mean, are there significant characteristics that you can look at on a CT, MRI, or PET?
CT and MRI are pretty good diagnostic capabilities for this. You can have these small internal septations in just a regular lipoma. It's especially with the ones that are traversing between multiple different compartments, and it's hard to tell exactly if they have true septations or these are just them kind of working through tissue planes. But if you're noticeable large septations or something that's just not totally fat, if you start to have different characteristics within the MRI of more dense structures, things like muscle or vasculature within the mass, which appear to be within the mass as well, not just fat. Those are the most worrisome characteristics that make you think you need to start preparing for some type of more oncologic procedure.
Well, would it be fair to say to everybody then, if somebody asked you that question, you'd say, well, this is symptomatic. This is a symptomatic mass. This patient is having symptoms from it, as near as we can tell. We're going to have to take it out anyway, and so we don't really need a biopsy.
Yes,
Because
sir.
it's not going to change your approach. You're not going to try pre-op radiation. It's pretty radiation insensitive, right?
Yes, sir.
No chemotherapy either. So the abbreviated answer is we're going to take it out anyway, which is what you said to start with. You're going to do it anyway, so, okay, all right. Dr. Nelson?
That was kind of my question. Would it have changed your surgical approach if you thought this was liposarcoma? Could you have gotten margins anywhere around that?
I think we would, as far as our approach to the peritoneum, and I think we could have had a little bit more ability to get some margins in the leg itself, but we couldn't have just destroyed her obturator canal and the membrane and everything like that to try to get margins around it. It would have definitely been a more difficult operation if it had been a high likelihood of a sarcoma of some kind. But it would have been very difficult to get clear margins on her. I mean, she would have been somebody that required.
Well, I mean, it was adjacent to both the neurovascular structures of the pelvis, right? I mean,
Yes, sir.
it ran right along, sort of followed them for a big part of it. Dr. Jean, you want to?
Yeah, so just a couple of comments about this. First of all, that was a good presentation. Second of all, I kind of agree with what Alan was saying. Is that this lady was pretty symptomatic from it, sort of a secondary symptom. She kind of complained mainly of the abdominal pain and the bladder symptoms, but upon questioning her, she did have some, pain in her leg as well. It was sort of radiating down her leg, but she just thought that was normal. She had been told that she had a problem with her spine that was causing her leg pain. So, so she did have those symptoms. The other caveat to this was that this patient was actually uninsured and paying for everything out of pocket. So it also made us kind of, I basically told her, talked to her about this, and she was saying, I'm symptomatic from this. I want this out regardless. And so any kind of biopsy, I think, would have been just an extra cost that didn't really change our approach. Because like you said, getting extensive wide margins on something like this would be, obviously increase the morbidity of the procedure. Just as a side note too, I've seen this lady for about probably 2 or 3 months now in post-op, and she's doing great. She's very, very appreciative of what we did. Initially, when she came back to me, she had a little bit of numbness in her thigh that was really not too significantly limiting to her, but that has since resolved, and she's really not having any symptoms related to this anymore. So she's very happy with it.
Okay, yeah, Dr. Maxwell?
I appreciate this case. The approach was very interesting. I haven't seen anything like that before. But I'll make a comment and a question. One, if this was a liposarcoma, I think you would have needed to do a hemipelvectomy to get negative margins. I don't think there's any way around that. I don't know that you'd want to do a procedure that morbid to somebody. I think you would excise it and then consider option for radiation to decrease the risk of recurrence. And my question is, was there a preperitoneal approach? You mentioned something about going transabdominal and lysing adhesions. Would there have been a way to stay extraperitoneal and have gotten this done? I mean, I don't think it made any difference in your outcome. I'm just curious if that would have been feasible after you look back on it.
You're talking about like a transplant incision and preperitoneal approach?
I don't know. That's a good question. I think it would have been very difficult just given the amount of force it took to do this. We had multiple people pushing and pulling in several directions. But I mean, it's definitely an interesting thought. I just think we had a very hard time getting it through the canal, and it sounded like the papers I'd written or read of other surgeons doing this also. I think it was actually interesting. The Mayo paper, they put like a plastic bag around part of it and help pull it through the canal through the other side. It was kind of an odd approach they made as well.
Didn't they reference a preperitoneal approach? Didn't you say that about that? case?
Oh, no, they did not do they did an abdominal approach as well. They entered the preperitoneal space, kind of similar to how we did. They went in actually more posteriorly through the presacral space and kind of went around.
So we kind of considered all of these approaches. We considered just doing, kind of like you said, a kidney transplant incision, staying extraperitoneal, as well as even, possibly doing the abdominal portion in a laparoscopic preperitoneal approach. But just given, I'm obviously not all that familiar with the obturator foramen, and, I did talk to some of the orthopedic surgeons about their approach, which from the leg, but I just, I felt like it would be better for our exposure. And obviously, like Alan said, as adherent as it was to the obturator foramen or the obturator canal, then I felt like just doing a transabdominal preperitoneal approach probably gave us our better exposure to free everything up. So, but we did talk about all of those options and opted to just do it this way.
With that much of, with that much of a dilatation of the obturator foramen, excuse me, you're going to follow her about the possible hernia through that area? Or, 'cause you
We
really
are,
have
but
nothing but your mesh
Right.
open, covering that, right?
Yeah, so we are, and I told her, I said, that's a possibility. Unlike a lot of other hernias, the obturator membrane is just solid. It's not like a lot of hernias where you can primarily close it, because you basically have bone on one side and this really, really tense, tissue on the other that there's no way to close. Plus you have, the obturator nerve and the obturator vessels going through there. So, and I told her, I said, we did what we could to cover that. Obviously it's not perfect, but my hope is that it'll service her, about as well as possible. And, looking at just different ways to repair an obturator hernia, I think that was sort of why we chose to go that direction.
Okay. Dr. Capote, you want to get ready? While Walter gets his slides up, I want to remind the residents that this is the last week for flu shots on the 12th floor of the POB. Everybody know that? And I think, unless I'm mistaken, you're required to have them. Is that not right, Dr. Greer? So be sure you get that done, because then we'll have to be finding a place for you to go to CVS or something to get them if we don't.
All right, good morning. Today I'm going to present a case of a surprising metastasis to the spine. I'd like to thank Dr. Giles for allowing me to be part of this case and for helping with this presentation. No disclosures. Brief outline, basically do a case presentation, review of the disease process in question, literature review, and then we'll a brief talk about the cost of medicine. Our case begins with it's an 84-year-old male. Overall, no significant medical problems. He presented to neurosurgery. He was referred because of 6 months history of right upper extremity pain and weakness. He had actually been going to PT, physical therapy treatment, and actually even undergone and surgery in his elbow to try to relieve these symptoms with no resolution. As stated, no significant past medical history. He did have a skin cancer that was removed of unspecified kind years earlier. No significant surgical history, either appendectomy, skin cancer, high blood pressure medications, and hydrocodone for pain, arthritis type pain. All his labs were within normal limits. He did have anemia with a hematocrit of 30 when he presented. This was a CT that was which he presented with neurosurgery for, and keep an eye on the spine. You can see a mass on that is on C7. He also had an MRI, and you can see the tumor causing compression on the spinal cord. And these are just kind of still shots, representative images of better look at the and you can see how it encompasses pretty much all parts of the vertebral body and spine. So he was taken to the operating room on the 19th of December, and by Dr. Gallagher, he debulked the tumor best he could. He did a fixation. They did send intraoperative frozen sections, and this was consistent with the carcinoma, but they had no definite origin. When I became involved, it was actually on post-op day 3. They consulted for a post-op ileus, and it was the same day that the pathology came back. And looking at the same scan, but this time keeping your eye on the area in the red circle, you can see a mass come into view right about there. And this is it right here, and that is on the right thyroid. The right lobe of thyroid, there's a nodule. I went back through his records, and you can see in 2015 he had several CTs for, he had, what best I could tell, elevated D-dimer, so he had several CTAs of his chest. And in each of those, you can see that there is a nodule and a mass on his thyroid, but this was not called by the radiologist in any of these CT scans. So ultimately, the final pathology did come back. It was a metastatic follicular thyroid cancer. That's the time he was referred to, Dr. Giles for further evaluation. His TSH was normal. He underwent a thyroid ultrasound with biopsy of the nodule, and this came back with Bethesda 3, which we'll talk about, but it was a follicular lesion of uncertain significance. He also had a suspicious left-sided lymph node that was biopsied, and this was just a benign lymph node. No other nodules or suspicious lymph nodes were seen. He underwent a total thyroidectomy without a lymph node dissection on the 23rd of March, and this was due to the fact that there was no clinically palpable or clinically suspicious nodes, and as we were to talk about, follicular cancer rarely metastasizes to lymph nodes. The pathology returned with a 1.5 centimeter follicular thyroid cancer, and also in the left lobe, unbeknownst at the time, he also had a papillary thyroid cancer that was a lot smaller and was not seen on the ultrasound. This correlates with the stage 4 follicular cancer and the stage 1 papillary cancer. He underwent radioactive iodine in June therapy, and he had a radioactive whole body scan 1 week later after administration of the pills, and he had uptake in the central and posterior neck consistent with small amount of remnant thyroid tissue and as well as the mass in the spine. But he also had some uptake in his pelvis, and a radiograph, which I don't have images of, did have lytic lesions, small lytic lesions in the left sacrum consistent with the metastasis. He also presented around that same time to neurosurgery again with the same symptoms, and he had repeat imaging, which kind of showed that the tumor was smaller than it was prior, but there was still some extension to the spinal canal and causing some symptoms. So he did go radiation therapy in July, 10 total treatments of that to help with the symptoms. Their surveillance plan right now for him would be a radioactive iodine scan in a year, and then yearly ultrasounds and TSH and thyroid globulin checks. So to talk about differentiated thyroid cancer, which is the most common type of thyroid cancer, and it's the most common endocrine malignancy worldwide. It is actually the 5th most common malignancy in women in the United States. An important note is that the incidence has been increasing, and this is not just in the U.S., as we'll talk about later, but worldwide, but 189% increase since 1973. The overall survival is excellent, especially in young individuals. Differentiated thyroid cancer, which include follicular, papillary, follicular, and Hürthle cell types. They're 90 to 95% of all thyroid cancers. So we'll focus our discussion on these. Some general principles. These are generally present as either a painless nodule that the patient or his primary care physician or another physician palpates, or they're an incidental finding on an imaging study. If they're usually asymptomatic, if there's any symptoms of hoarseness, dysphagia, or any other respiratory symptoms, these are usually associated with a larger tumor and worse prognosis. And age is the best prognostic indicator for these patients. You can see on this chart on the right side, on the top hand, the top graph, you can see stratified by age. You see younger individuals have excellent survival. And as you age, usually you see in the blue line, individuals over 60, their survival kind of is significantly worse than the younger individuals. The bottom graph shows stratified based on papillary, which is the red line, and then the two different types, either well-differentiated versus poorly differentiated follicular cancer. And you can see follicular cancers are associated with a worse survival. Just a brief mention of genetics. 5 to 10% of these are considered familial, with some genetic hereditary component. Most of these are thought to be sporadic in nature. There is genetic testing is something that's done for these lesions in the workup part of the process. Usually Bethesda 3 and 4 lesions are the ones that are submitted for genetic testing. The American Thyroid Association actually does not have any specific recommendations for this because there's still there is still some debate of whether this is useful or not. There's still a lot of research undergoing. But nonetheless, it is used widely. The staging for these lesions is typical TNM staging. This T is depending on the size and whether or not there's extrathyroidal extension, and just metastasis, and then M obviously for just metastasis in general. For staging, there's a very peculiar thing with thyroid cancers, and that is in young individuals, and this was recently raised to 55 years old from 45 years old, just last year actually. But people under 55 cannot be higher than a stage 2, regardless of if there's metastasis or not. And I think that was an abstract question at some point. And our patient here, over 55 with metastasis, obviously that makes him a stage 4B. Papillary thyroid cancers are the most common of the differentiated thyroid cancers, and ionizing radiation, whether it's a child, usually a child is exposed to higher risks, but that is the #1 risk factor and is the only actual environmental factor that's been definitively identified. There is some family history and some familial syndromes that can be associated with them. Interestingly, in autopsy series, microcarcinomas defined as papillary thyroid cancers less than 1 centimeter are seen in about 30% of cases. And this kind of implies that a lot of these are minimally clinically significant. The diagnosis can be made on an FNA. That is because this is a problem in the nuclear structure that you can see on just by looking at the cells. The things that you normally see would be the intranuclear inclusion bodies, and the psammoma bodies are the commonly the keywords that you hear. There is a follicular variant of papillary thyroid cancer, and it's very similar in prognosis and treatment to just normal papillary thyroid cancer. PTC does spread via lymphatics primarily. Lymph node metastasis is pretty common with these, but survival usually has not been shown to be affected, at least significantly, by lymph node spread. Follicular thyroid cancer is actually associated with areas of iodine insufficiency and is a lot less related to radiation exposure compared to papillary types. The FNA is not diagnostic. You need to show the architecture of the tissue and show invasion of the capsule or the vascular structures by the tumor in order to diagnose this. And this presents a problem with working up thyroid nodules, as we'll talk about in just a minute. These typically spread via hematogenous route, and lymph node metastasis is a lot more rare with these. When they do spread, it's usually to the bone or to the lungs, would be the most common sites. And different from papillary types, follicular cancers, even small ones, are clinically significant, and that is because they're higher propensity to spread. Prognosis and response to radioactive iodine therapy does worsen with age, and that actually applies to both. Hurtho cells is basically just a subtype of follicular carcinoma that is more aggressive in nature, and it's the oxyphytic cells with increased number of mitochondria is one of the defining features. The important note is that it's more aggressive and less responsive to treatment. As far as treatment for these tumors, traditionally everyone with a thyroid cancer received a total thyroidectomy. Now there's a greater push for less aggressive surgical approaches. A thyroid lobectomy is appropriate for small lesions. These are lesions with less than 1 centimeter and with no extrathyroidal or lymph node involvement. You can consider no surgery for such lesions as well. Low-risk lesions, lesions that have very benign appearing sonographic findings would be appropriate for just a lobectomy. And this is lower rates of bilateral recurrent laryngeal nerve damage, lower rates of hypoparathyroidism, and you have preserved thyroid function. Near total thyroidectomy, that is performed only basically if you have concern for the nerve, and it's defined as leaving less than 1 gram of tissue on one side. And the total thyroidectomy is still is the more common approach for thyroid cancers. And for higher risk tumors, or if you plan on doing radioactive iodine, then this is the procedure of choice. And it also allows screening with thyroglobulin levels in the future. Completion thyroidectomy is when usually performed whenever a thyroid cancer is found on a lobectomy that was performed for a goiter or another reason. The recommendation is to only perform a completion thyroidectomy if knowing the original pathology before the case would have led to a total thyroidectomy. So if a small 0.5 centimeter papillary cancer is found incidentally, then you should not go and perform a completion thyroidectomy. There are different ways to stratify these patients based on low or high risk. As we talked about, age is the big one. Males have a higher risk of having a thyroid cancer or having a more aggressive type of cancer. Obviously, if there's any capsular invasion or extrathyroidal extension, that's higher risk. Size, usually 4 centimeters is the cutoff that's used as a high risk versus low risk, and as well as poorly differentiated, as with other cancers, implies a higher risk. When it comes to lymph node dissections, central neck dissection should be performed if there's any suspicion for clinically pathologic nodes. Some surgeons will advocate doing a prophylactic dissection for everyone. However, this is associated with higher rates of complications. Lateral neck dissections are reserved only for if there's a lymph node that's seen preoperatively in the lateral neck that's you're concerned about. There is no role for prophylactic lateral neck dissections. So the level 6 is the central neck compartment that you would typically explore. Brief radioactive iodine has been used since the 40s. It's the beta particles of the iodine that cause cell death. And there's 3 reasons to use iodine therapy. One is to destroy any remnant tissue, and that allows detecting recurrence by means of thyroglobulin or iodine scans in the future. Any occult metastatic disease will, in theory, be taken care of by iodine ablation therapy. And you can also use it, obviously, for any known metastatic disease as treatment. And just like with surgery, this trend is growing towards more selective use of radioactive iodine therapy. In the past, it seemed like most people got this. Now, it's usually metastatic lesions or significant lymph node involvement or high-risk disease that receives or should receive radioactive iodine therapy. Preparing people to have this therapy, you need to lower their total iodine level in their body. You do this with a low iodine diet. Of note, CT scans with iodinated contrast can take up to 4 weeks to clear. that iodine load, and it can delay treatment significantly. Preoperatively, people usually don't receive this treatment until 4 weeks after their surgery. But after they've had a thyroidectomy, you should be careful about ordering iodinated scans on these patients if radioactive iodine is in their future. I found this very interesting. Amiodarone can take months to years to actually clear from the blood, at least in regards to the iodine. And some people even need plasmapheresis to clear this. You need high TSH levels to stimulate uptake of the iodine, and there's 2 ways to do that. One is to withdraw their thyroid medication and essentially make them hypothyroid. You want TSH levels over 30 is the typically quoted number. And newer approaches use recombinant human TSH. The benefit of this is that it avoids hypothyroidism, and because euthyroid states clear iodine faster, they have a lower total body radiation exposure. Of note, there's no long-term randomized trials comparing these 2 approaches as far as disease survival, but short-term data does imply that they're equal. Complications of RI therapy, sialadenitis, xerostomia, nasolacrimal duct obstructions. The big concern that people have is secondary malignancies, and usually this would be salivary glands or leukemia or other myelodysplastic syndromes. The absolute risk increase is low, but there is a high relative risk increase. Pregnancy and breastfeeding are the only contraindications, or definite contraindications to this therapy. So the ATA has put out kind of recommendations based on risks as far as which patients should receive radioactive iodine. And only high-risk patients, or those with a T4 or M1 lesions, have been shown to have overall benefit from getting this therapy regarding disease survival. The people in the middle, it's left mostly to the surgeon, but typically, if there's no tumor involvement of lymph nodes, or they're smaller than 4 centimeters, the overall recommendation is to avoid radioactive iodine for low-risk lesions. Tumors can be resistant, especially in older individuals. They can even be resistant to external beam radiation. They can be resistant to TSH suppression. And there's novel drugs being investigated. They're kinase inhibitors, as well as systemic chemotherapy. Important to note that these are usually tumorostatic. They do not usually result in cure. And the general guidelines is if only large, rapid tumors that are rapidly growing tumors that are symptomatic should receive any sort of these types of treatment, and either a multikinase inhibitor such as lenvatinib, which is the most commonly one used, or otherwise use chemotherapy only as a final option. TSH suppression is used postoperatively to minimize the risk of stimulating thyroid tissue. Basically, you make the patient just slightly hyperthyroid, just to keep that TSH at a very low level. And depending on how the level of risk in their tumor, then that determines how low you want their TSH. Obviously, the lower you go, the more risk you have of causing hyperthyroid symptoms. So all this is what I was really interested in was the incidental thyroid nodule. And that is defined as one that is detected in an imaging study for another process that was not suspected in any way. These can be seen in 25% of contrasted CT scans of the chest. And I think everyone that's done trauma knows how common these can be. Most are small, benign, or if they are malignant, they're very indolent with low risk of potential harm. The problem is that if when these get worked up and biopsies come back as benign or malignant, that leads that they're not benign or malignant. There's a multitude of tests and procedures and expenses that increase anxiety and morbidity among our patients. There's been studies that have shown that 25 to 41% of incidental thyroid nodules that undergo a biopsy will proceed to surgery. And a good depending on the source of most of these will be benign. There was a study in Japan of 340 patients that had known untreated papillary microcarcinomas, so less than 1 centimeter, and there was no cancer deaths in a 10-year period, and only 3% of the patients had any nodal metastasis at the end of the 10 years. This is the algorithm that is used to work up any thyroid nodule, and you just usually start the TSH. If you're hyperfunctioning, then you do the radioisotope scan to check for a hot nodule. If their TSH is normal, then you do the ultrasound, and depending on the characteristics and the size of the lesion, then you proceed to a biopsy or fine needle, and that leads to the Bethesda criteria report. And depending on what that shows, then you either follow up, repeat the biopsy, or just go straight to surgery. Just briefly, this is just some of the sonographic findings that would incline you to think something is a cancer. Cysts of note are statistically benign. Very, very, very rarely will this be a cancer. This is the Bethesda criteria. Basically, it ranges from non-diagnostic, benign, the AUS category, which is where our patient fell, and then follicular neoplasm, or suspicious for follicular neoplasm, and then suspicious for malignancy and malignant. So 3 and 4 are the ones that always cause problems because they do not give a definitive diagnosis, and that is because, again, follicular cancer cannot be diagnosed in a fine needle aspiration. So that is where the problem lies, that all the lesions that come back as 3 or 4 undergo either repeat biopsy, or they undergo expensive genetic testing, or they undergo surgery for often benign lesions. This is a paper from, or article that was in the New England Journal of Medicine in 2014, and it describes in Korea there was a push for increased cancer screening in 1999, and they started including thyroid scans in these treatment plans for a small fee, and they actually started marketing thyroid ultrasounds as part of just a normal health checkup. And what they saw is that their incidence of thyroid cancer went up 15 times in a span of from 93 to 2011. And most of these patients actually underwent surgery. 2/3 received radical thyroidectomies, and 1/3 subtotal thyroidectomies. And there was, in one of these hospitals, they saw that in 95, 14% of their thyroidectomies had tumors less than 1 centimeter. 10 years later, it was 56%. So they were taking out smaller tumors that likely would have not led to any morbidity or mortality for these patients. They also saw that 15,000 Koreans who underwent surgery, 11% had hypoparathyroidism, and 2% had vocal cord paralysis. This is not unique to Korea. This is another paper from Italy, and you can see the yellow line, the middle line, and the top line shows incidence stratified by age, and you can see between 98 and 2012 how the incidence progressively increased in both men and women. This was also attributed to overdiagnosis via excessive workup for these nodules. This, just briefly, this is a study that I found interesting and kind of highlights why this is important. They did a study using Likert scales of basically quality of life. These are subjective. And they compared patients who had survived colon cancer, brain cancer, breast cancer, and gynecologic cancers, as well as thyroid cancers. And they saw that the quality of life scores that patients were expressing, they were equal to these other cancers, despite that the overall survival is significantly much better for thyroid cancers, which is 98%, 10-year survival or 5-year survival, compared to 65% for colon cancer, 35% for brain cancer, and 81% for breast cancer. So despite having a much better prognosis, the overall quality of life was equal that the patients were feeling. And this has been attributed to either the hypothyroid state associated with getting treated for thyroid cancer, as well as, interestingly, and I found several papers talking about this, was that the caregivers often will tell patients that thyroid is a good kind of cancer, and Some patients feel that they're trivialized, their diagnosis is trivialized, and not given the same level of care as maybe other types of cancers. The current recommendations by the American Thyroid Association are to ultrasound every thyroid nodule that you find. There has been a 3-tiered system for evaluating nodules that has been suggested. Basically, any nodules with any suspicious findings should be biopsied, and nodules greater than 1 centimeter if you're under 35, and greater than 1.5 centimeters if you're over 35. This results in a 35% reduction in ultrasound-guided biopsies. There is a missed malignancy rate of about 1.2% with this method, but the missed cancers are likely to be very small papillary tumors that would be clinically insignificant in the long run. This is a paper from the American College of Radiology talking about how they would manage incidental thyroid findings. Make a point to express that these recommendations are only for patients they don't apply to patients with increased risk. So patients that have had exposure to radiation, patients who have a family history or who are symptomatic from thyroid disease should not follow these sort of recommendations. They also made an emphasis not to call these guidelines because there's still a lot of research, and this is merely recommendations based on their experience and available research data. And I'll come back to this quote I liked, but basically, for CT or MRI, their recommendations are if there's a finding and it's suspicious defined as having involved lymph nodes that you can see on the CT scan greater than 1.5 centimeters, or if there's calcifications or cystic components to the mass, then all these people should undergo a thyroid ultrasound. But if there's no CT or MRI findings that are suspicious, then in the general population, people under 35, if it's less than 1 centimeter, they recommend you leave it alone. Do not do an ultrasound. Do not check TSH. Just let it be. If they're greater than 1 centimeter, then ultrasound. And then 1.5 centimeters is a cutoff for people over 35. If somebody has a limited life expectancy, so the 92-year-old grandma that fell in the trauma service, who has dementia, any thyroid nodule seen on her scan should not be further worked up. On PET scans, things are a little bit different, and that is because PET scans, there's 11 to 13% chance of malignancy with uptake on a PET scan. So any uptake on a PET or PET CT should be worked up with the ultrasound, again, unless there is limited extensive comorbidity or short life expectancy. This paper where these charts came from, they recommend against mentioning incidental thyroid nodules in the impression or conclusion of a report by radiologists if the size does not meet the criteria for further evaluation. And I thought that was an interesting thing they mentioned. Briefly on the cost of medicine, I tried finding out how much a radioactive iodine treatment costs. I talked to the nuclear medicine staff here, and a 50 millicurie radioactive iodine tablet is about $2,000. Our patient received 170 millicuries, so he would have gotten some combination of a 150 millicurie tablet and another, and that's about $3,500 to $4,000. And that is the hospital cost. And here you see, I'm not sure you can see that very well from where you're at, but these are Medicare reimbursement rates for associated with thyroid radioactive iodine therapy. And of note, I wanted so the recombinant TSH is about $1,000 per injection. Usually it's 2 injections. And the radioactive iodine capsules, Medicare reimburses about $18.50 per millicurie. So, 100 millicuries, that's $1,800 that Medicare reimburses for that. And you can see there's a lot of costs associated with all the different treatments and tests and things that people undergoing these therapies are exposed to. These are my sources, and I'd like to take any questions.
Well, that's about as complete as you get with this. I would encourage people to get these slides because, again, this is something that you can expect to have significant questions about. We're about out of time. Any brief comments, Heath, you want to add anything? Or Mike, now, Dr. Rowe?
Just appreciate the exhaustive review. But one comment, one question. One, that paper from the radiologist about commenting based on clinical criteria, that's never going to occur, okay? Because they don't ever know the clinical criteria, and they tend to mention every tiny 4-6 millimeter nodule as suspicious and worthy of biopsy. So that's one, and we see those patients and don't biopsy them. So that would be one. The question I had was, in this scenario, if you were confident in the pathology from the Met to begin with, and we knew we had a 1.5, 2 centimeter nodule, what was the value? What in doing the FNA? Was there anything that could tell you that would prevent you from recommending a total thyroidectomy?
From biopsying a 2 centimeter nodule?
Yeah, why would you biopsy it? If you already know that there's metastatic follicular thyroid cancer, you've got a nodule that's been there for a couple of years, it's not rapidly growing to make you think it's anaplastic. What would the biopsy show you that might lead you to not doing thyroid surgery?
So I think with the metastatic disease, you're almost married to the total thyroidectomy, just so you can do the radioactive iodine treatment post-operatively.
Why did we do the biopsy? That's the question.
I don't think he's understanding your question.
Yeah,
What?
That's probably a question for me.
Yeah.
What's
I guess
the answer?
Because he wasn't involved in
Yeah,
this.
because follicular the biopsies all come back follicular of unknown.
That's correct. And just to remember back, it's hard to remember exactly what my thought process was, but if I remember right, he had nodules on the other side and he had a node in that lateral neck that I wasn't quite sure about. And so I was going to biopsy that node just to be sure there wasn't some other process happening. And while I was there, because he had nodules on both sides, I went ahead and biopsied the one that I thought was the most suspicious, just to kind of confirm what I was dealing with. I knew he had metastatic follicular cancer and we were going to do a total, but I didn't know if there was some other process.
If you didn't have anything in the lateral neck, would you even mess with it?
Probably no. No, if there wasn't anything in the lateral neck, I wouldn't have biopsied his. I was there anyways, and I was going to biopsy that node.
Do surgery, it was just
Right. Yeah. Yeah. That was for me. That was more for me than anything else, probably.
Okay. Let me just mention several things. One of them for the residents. One of the points that I really appreciate you bringing up about the quality of life study, because while that sounds touchy-feely to a lot of us surgeons, that's where an awful lot of research is headed, and it's one of the things that in your tenure as doctors you're going to need to pay attention to, and that's what we don't do enough of in medicine, and that is how do we really affect the long-term lifespan and quality of life of the people that we treat. And it's one of the things you guys are going to have to concentrate on, because just because we can do it doesn't mean it's a good thing to do always. And thyroid surgery has been one of them, as you really, if you look at so many of the things that you pointed out, Walter, you know, it referenced that. So that I thought that was particularly good. The point about radiology is that Dr. Rowe made is exactly right. We have the same thing in breast. The number of women I have to talk down off of the ledge about something that a radiologist has identified as something that is suspicious and has to be done. I mean, it's every day. It's an everyday occurrence. So you're going to have to do that. So you can't get away from, with all of computerized medicine and assembly line medicine, you can't get away from going and looking at the x-rays yourself and putting it in context. And that's what you have to do as a surgeon an awful lot of times. Thyroid and breast happen to be two that it's really particularly pressure-packed with, I think. There were a lot of things about your talk that we could discuss, but unfortunately we're out of time. I want to mention again about the flu vaccine. And I want to introduce Dr. Craig Murray. Craig, raise your hand there. Joining our faculty. He's going to be working with you guys. Starting more next month, but we look forward to his participation. He's had great experience at the Medical University of South Carolina for a while, and then down in Albany with one of our graduates practicing down there as well. So we're really happy to have Craig with us and look forward to having you here. Appreciate you being here today. We got to stop. We're 10 minutes past due.
I want to make one
Go
quick
ahead.
announcement for those of the residents that are here. Halloween night, anybody who wants to come up to our place, Dr. Rowe can attest to how crazy trick-or-treating is in our neighborhood. And so anybody specifically with kids, if you've got kids and you want to bring them up to our neighborhood and trick-or-treat from my house, I think that would be a lot.